Welcome to the to North Carolina and to our Blocktober live scanning event. My name is Jeff.
I'm Stuart.
And we're so delighted and thrilled to have you guys here with us. So we're going to do an hour with you of your requests. You tell us what you want demonstrated in the chat, and we'll make it happen. We have an ultrasound machine. We have a model. We may have had some whiskey.
Just a little bit.
But it's gonna be fantastic. So we've already got some requests coming in. What do we want to see first?
I think the first one we saw was a Pecs, Serratus was the first that I saw on the live chat.
Pecs and Serratus. Okay, so we've got James here.
I'm going to switch over. There's the James cam.
James cam. We got we got James from ultrasoundmodels.com. He's actually one of our fellows at Duke, regional fellows, and so he's kindly offered to help us out here. So for the Pecs block, and this is a block we use for chest wall indication, so a lot of breast surgery or minimally invasive cardiothoracic surgery or thoracic procedures. I like to start with a linear probe on the chest wall as if I were starting to do a infraclavicular brachial plexus block. And so I'll start right here. If I can feel for the coracoid process, which I can barely feel in him because he's got some good pec muscles, I'll put the probe on just medial to that, and you can see a really nice infraclav view. You can see his pec major muscle, pec minor muscle, artery, and vein. Now, were I to want to do infraclavicular brachial plexus, I would try to get my local anesthetic right to about there at 6 o'clock to the artery. But I don't. I'm just using this as a starting point. What I want to do now is two maneuvers with my probe. I want to tilt medial, and then I'm going to twist so I'm kind of in line with the delta pectoral groove. And you saw what happened there. It brought a rib up into the picture. Let me do that again. So there's infraclavicular view, straight parasagittal, tilt, and twist. And there's a rib now underneath the vessel. So you can see the shadow of the rib. That's the second rib. And I do that so I know what rib is what. And now it's easy. Now we're almost home free. I'm going to drag my probe in the direction that it's pointing, this way. And there's rib 3. And if I lose my rib, if it becomes a bit fuzzy, like it is now, that means I'm not tilting medial enough. So I'm just going to tilt a bit more medial, and there it is. It's nice and crisp again. So there's where I would do my interpectoral block, or Pecs 1 as I used to call it. So in the plane here between Pecs major and minor, that's where the lateral medial pectoral nerves live, and where we put our local there for Pecs 1. Then we'll keep going, and you see I'm sort of traveling around the chest wall, and there's a fourth rib. And you can see we've picked up a new muscle. We've got Pec major and minor. We've also got a muscle here. You can see where the crosshairs is. That's just above the rib, and that's serratus, serratus anterior. So the original description for Pecs 2 was to put the local here between Pec minor and serratus in this plane, and that works great. 20 mils right there, or you can put it right on top of the rib. There are patients with all scan. I don't know if you feel the same way, Stuart. You just can't get a really good view of that plane, but you can see the fourth rib really easily. So I'll just put the local right on the fourth rib.
Yeah, I think one of the mistakes people make with this is they tend not to have the probe flat enough. We go back and actually just look at where the most common mistake, the probe is pretty vertical, and people
like that.
Yeah.
And you can see we're losing our rib view there. Yeah.
Let me just show you the view. Put that probe flat. Lovely view of the rib.
Thank you, James.
And then if you put the probe vertical, so often people are struggling to find the rib, so make sure you have the probe flat. That's one of the best beginner tips.
Yeah, I agree. And that's it. And typically we'll do, if we're doing both, and remember the Pecs 2, or the pectoserratus block as it's called now, gets the skin, the subcutaneous tissue of the chest wall, the lateral cutaneous nerves of T2 through T6 or so, and the Pecs 1 gets the pectoral nerves, which just get the pec muscles themselves. And so we don't always do both, but if we are doing both, I'll typically do this Pecs 2 first, and on my way out, my needle will fall into that plane for Pecs 1. And then done and dusted. All right, and I think you said serratus as well?
Serratus,
yeah. So serratus is a very similar block to Pecs 2. We use this mostly for lateral rib fractures and some thoracoscopic surgery. So again, it gets a broad expanse of the lateral chest wall. This is a really super easy one. I usually find the nipple, mid-axillary line, put the probe on transversely like that, and you'll see some ribs. Get those calipers out of the way. You see ribs and pleura. I'm going to take our depth down a bit here. Now the muscle that's traveling, that dark muscle traveling on top of the ribs, that's serratus by definition. It has to be where we are right now. What I can't see is latissimus dorsi muscle, and to do that I'm going to drag my probe down towards the bed. Here we go. And as I do, you see latissimus come in here. Where's our caliper? There we go. So this is latissimus, and this is our plane here between serratus and lat. And so what I would do is hold my probe like this, bring my needle in like so, from anterior, and just enter that plane and hydrodissect and unzipper that plane to get all the local volume block here. So 20 to 40 mils, depending on your indication and how much you want to get out of it. But that's a really, really nice, easy one. And it accommodates a catheter well, too. So we'll often put serratus catheters in for rib fractures. And it's nice because you can have the patient supine. The orthotrauma doctors can be working on the lower limb, fixing up the ankle fracture, and you can take care of the rib fractures while the patient's asleep. All right. What's next?
So we're all over the anatomy, head to toe. A couple of people have asked for the PENG block.
The PENG block. Okay, let's do that.
Say hi to Philip PENG if he's watching. I don't know if I was watching, but okay.
I am going to, the PENG block, so what do you use PENG block for while I'm setting up?
We use it for hip fractures. Tried it when I was learning it. I tried it at the ambulatory surgery centre and I had a heavy leg, so I don't think I was doing it right the first time, to be honest. Got a little bit of femoral nerve block, but certainly we use it for rib fractures.
Terrific. So what I'll do, we're going to keep James reasonably modest and keep him off the...
This is a family show.
It's a family show. Tune into our Jeff and Stu After Dark if you want to see the other version. But I'm going to put the probe just medial to his anterior superior iliac spine, where's my finger right here, the ASIS. Okay, so, and ultimately what I'm doing, and you see I'm using a curve probe here.
Yeah, okay.
I'm aiming to put this probe in his inguinal crease.
Okay, what I'm going to do is show the ultrasound as you're doing that. Let's go for a picture shot. Okay.
I'm going to take my depth down. Okay, that's great. I'm going to actually, I do this mostly in patients that don't have shorts on, so I'm going to start with how I usually start to see this picture, which is like this. And your normal first thing you're going to see is the pulsating femoral artery, and that's a good landmark. So then we're going to look a bit deep. And usually what I'll see is the nice rounded head of the femur. You can see James's femur there in the corner over here. So that's a good sign. It's not where you want to go, but it's a good initial landmark because you know all you have to do now is shift your probe up just by about 1 centimeter, and there we go. We see our nice wavy, gravy expanse of pelvic brim as it comes across the screen. So over here on the lateral side is our AIIS, the ice, and then it comes down into this trough. This is all bone, pelvic brim, and over to here, to the iliopubic eminence, as it's called. Femoral artery up here. Femoral nerve is up here. We don't want to get that, right? Because the whole point of the PENG block is it's a motor-sparing way to get the branches to the hip joint. So we're going to bring our needle in from lateral, coming across through iliacus muscle, and then we're going to hit the bone. This is our psoas tendon, this hyperechoic structure here. And the initial description had the needle sort of jamming in underneath the psoas tendon. I find that when I've done that, it sometimes is very, very hard to inject. And so I kind of just now land right about here, just a few millimeters away, and it does a good job. Tips for success. Make sure you're truly underneath that muscle. If you are in the muscle, we have had some leg weakness.
Yeah, and we looked in a cadaver lab. We were dissecting cadavers, UNC, and we did 10 injections, and a couple of them we felt it tough and we thought were beneath the tendon. Looking at an ultrasound, And then we dissected out the cadavers, we found the local anaesthetic had shot up the psoas muscle, and I think that probably is why we get some weakness. The other thing, Monica Nanda, she came up with we looked carefully and we noticed that be careful with your needle entry point, because we actually left a wire in there and we saw the track of the needle was very often right through the lateral femorocutaneous nerve.
Yeah, and it's hard to see with this curved probe.
Because you're a curved probe, you're looking deeper. It's actually difficult to see it's often difficult to see that superficial and see what the LFCN is. But just, I think just be careful.
Yeah.
Got a question here, a comment for Adductor about the PENG block. Because doesn't the local get sucked out when you do the block in pre-op when the surgeon gets into the hip? Yeah, if you've ever watched our surgeons prepping for surgery, there's a little bit of time passes between when we do the block pre-op and they actually get in there. I think the locals have his chance to do what it needs to do.
Is that soak time? Yeah.
Yeah, but no, good comment. Maybe if you're doing it in the OR, doing it just before, maybe that's something to consider. You could lose some of the volume when the surgeon gets down there. I wish your surgeons were quick enough to actually make that a problem.
Yeah, we did some cadaver stuff too with some blue dye, and it just spread all over that joint capsule too. So I think it's with that 15 to 20 mils, it does a good job of getting that whole thing.
Excellent.
I do use a curve probe for this mostly because you can see that nice coast to coast view of that pelvic brim, but you can, in a little old lady who's 50 kilos, use a linear probe.
Yep.
All right.
So we've been saying hello to a few folks on here, folks in the UK, got South America, Colombia representing, Turkey, Philippines.
Fantastic.
We don't have Antarctica yet, but it's only a matter of time.
There's always hope.
Wait, when you are here, can you do, people have asked for the suprainguinal fascia iliaca.
Oh, yeah.
When I start with fellows, sometimes orienting this anatomy is sometimes people find difficult. There's various descriptions. One thing I think is sometimes difficult, not in a model like this, who is young and muscular, but in older patients where there is no anterior abdominal wall. The bow tie, there's only one half of the bow tie is there. The other half is like wafer thin.
It's like me at the end of
it. But we'll go over and have a little look at anatomy. So let's put on the scan cam, and then we'll put on the ultrasound.
Now this is where that anterior superior iliac spine really comes in handy. So I got my finger on his ASIS, and that tells me exactly where to put my probe, just medial to that. And you can see I'm seeing some musculature. I don't see any bones yet, and that's okay. From here, I'm going to slide down south. Let me give myself a bit more depth. And what I'm going to aim to see is that. So I am seeing that bright white thing at the... I sure can. Yeah, so that bright white thing at the bottom is a pelvic brim. That nice rainbow of darker muscle is iliacus muscle. And so the right of the screen is his thigh, and the left of the screen is his abdomen. And you can see up top, over here is a bit of abdominal muscle, so internal oblique. And you can appreciate this fascia iliaca that lines the surface of iliacus muscle. And this is where I'll start the block. And I'll come from the thigh side. So you can see my finger sort of indenting the tissue on that lower side. By the way, there's a sartorius muscle. So there's the bow tie view, if you will. You got sartorius on the on the right-hand side as one half of the bow tie. There's internal oblique as the other half of the bow tie. And the inguinal ligament is right in the center there where the hash mark is. So I'm going to bring a needle in from caudad heading north. You can see in him it's very shallow. It's only about 1 centimeter. And I would aim to go and then through the fascia. And you're opening up this potential space between the muscle and the lining of the iliacus fascia that lines it. So pitfalls here are getting intramuscular, and this happens a lot. I mean, usually my first injection is intramuscular because it's to get through the fascia, sometimes you go a bit too far. So give a little squirt of saline, and then I'll drag it back a bit, another squirt, drag it back, and then finally you'll see that beautiful unzippering of that, and the local goes down. Now you can see where the center of the screen is. That iliacus muscle comes up to a pinch point. It's compressed there between the inguinal ligament and the bone. That's a hydraulic barrier to fluid, and if you put fluid on the pelvic side of it, it'll all go into the pelvis where you want it to go. If you put it on the thigh side, it'll go into the thigh, and you'll get a really good femoral block, but not the other components, right? Agree?
Yeah.
So you really try to get that needle tip just above. Now the other landmark that we can often see here in the pelvic side is the deep circumflex iliac artery, which lies just on top of the iliacus fascia.
Was a bit high there, might not see it. Oh, there you go.
That's a little flicker of it there. There.
Yeah.
So it's not so robust in James. There it is there, yeah. But that's a good landmark, and particularly because if you see, you see it better in 2D without the color actually. If you see your local going over top of that, you know you're in the wrong spot because that lies on top of the fascia iliaca and your local should be going underneath that vessel. But another good thing to stay away from too, don't push your needle so far that it's at risk of hitting those vessels. All right. Good one. We use this for I mean, this has got a lot of indications. Hip replacement, hip fracture. It's a true 3-in-1 block, right? For amputation. A lot of good lower limb thigh indications.
Yeah, there's actually a Cochrane review said we don't need any more studies. It works for hip fractures. Fascia iliaca.
Yeah.
Part of the Cochrane review, I think Sandy Kopp wrote that, says, enough already. We don't need any more studies telling us that this is a great block.
You've convinced us.
For hip fractures. So we know that's something that definitely makes a difference. And we've tried to get down to the emergency department and get these in as soon as possible. They're a combination at UNC, where I'm now, of trying to get the ED docs, getting them do it. At Duke, the model we set up there was
we go down.
The regional team goes down, but I think trying to get this done as early as you can. I think the biggest benefit is the frailest patients. Somebody running for the bus falls over, fine. If somebody falls off the toilet and breaks their hip and they've got multiple pathologies, they're going to be the longer workup before they arrive. And those ones I'm going to consider a catheter beforehand, try and minimise the opioids beforehand. I think the benefit there is better for those patients. Got loads of folk tuning in, lots of questions. Somebody asked for the costoclavicular approach to the brachial plexus early on.
Oh, that's the sexy new kid on the block, as it were.
So yeah. So costoclavicular approach. People who
you were called that once, I think.
The sexy new kid on the block. That was the last century. So it's interesting. People have talked about doing this for shoulder surgery. They say it spreads up the shoulder, and I think that's a big contraindication. If I don't want to get a frontal air block all the time, so maybe as a frail patients, a reason not to do this block if it's spreading up there.
Yeah, it's interesting, right? Like if
I'd rather still do something above the clavicle for a shoulder.
For shoulder,
to be honest, it's a long way for a shortcut, but
it's interesting.
Let's
interesting.
look at this.
Okay, so what we're going to do for the costoclavicular, and the idea here is that it is an approach to infraclavicular brachial plexus block, and the reason we're changing the probe orientation is so that we can see the 3 chords all clustered on one side. So if you think about the original, let's call it parasagittal, paracoracoid approach to the infraclavicular, you have our 3 chords here on sort of around the artery. And so what does that mean? I mean, to me, not much. You can put local at 6 o'clock and get a good block. But if you want to get them all nicely packaged together, we turn our probe so it's in line with the clavicle. And you can see, there's our axillary artery. I'll take our depth down a bit. And you can see here that we have artery here. We have all of our brachial plexus on one side. So you don't have to worry about, is my local going to get around to this side to get to one of the chords of the brachial plexus. That's the subclavius muscle that's attached to the clavicle, and then underneath here is serratus anterior, and you can see obviously chest wall with pleura down here, and a bit of pec muscle up top. So the approach to this, there are two approaches. The most common one we'll do is come from lateral, and so that'll be coming in from the left-hand side of the screen, so this way, and trying to peel that plexus away from the muscles on either side, the subclavius and the serratus. we're getting into a bit of controversial territory here because there are.
I love controversial.
Yeah, I know you're not a very opinionated guy, Stu.
No.
Yeah, you're very
shy.
Wallflower. So there are descriptions of this technique where the needle is put into the middle of that cluster and then poof, blow it up. I'm not a fan of that. I think the block works well. That's a decent shot there. If you can get the local between the plexus sheath and the surrounding muscles. Thoughts?
Okay. The problem I have with that is most of the time when I'm looking, there's a lot of nerve tissue in the Kevlar end and the clavicle's in the way, and more often than not, it's almost impossible to get there without hitting some of those branches of the nerves.
The other, I agree. I think it takes a lot of finesse to do.
That's where I'm going.
This block. The other things to be cautious of that we're seeing now on the screen is there are some vessels there. So you see this cephalic vein here. If I just tilt the right way, you can see this cephalic vein coming right over top of the plexus. And there's also a branch of the thoracocrimular artery that will run across there. There it is there. So just things to watch out for as you're putting your needle through. I think there's a question about a catheter. If you were to leave a catheter there, I think just like a supraclavicular catheter, I'd just try to get the space opened up, put the catheter in beside the plexus, and let the bolus seep across the plexus sheath.
Okay.
As opposed to inside the middle of it.
But this is the old way.
This is the old.
You're going to go more proximal and medial for me.
Proximal and medial.
Yeah, let's go.
What? By the way, what does this remind you of? What picture does this remind you of?
It reminds me of the
artery, and then
supraclavicular.
Right. This is a mirror image of supraclavicular. So if you look at the probe orientation, here's his clavicle. We're looking up underneath the clavicle, just like if we did supraclavicular, down from the top of the clavicle. There we go. So really, it's kind of like a different approach to the supraclavicular brachial plexus block. You should expect to get the same things.
Yep. I'm going to say thanks to everybody who's tuned in. Okay, I want to do that. I also want to say thank you to our local folks at Sonosite who helped us with the supply of the ultrasound machine. We don't have to have one just in the Grant family basement most nights of the week. I also want to take a chance to do a couple of plugs. One is for the Blocktober pub trivia event.
Yep, coming up next weekend, next Saturday. Not this coming Saturday, the Saturday after, 28th. Yep, Stu and I will be hosting a pub trivia night. So get your trivia team together, team game, there'll be prizes, and we'll see how much you know and how much we know about regional anesthesia.
Yeah,
maybe not.
We're going to think of questions that we can actually know the answer to, so it shouldn't be too tough. Hopefully a bit of fun. Pub quiz, maybe a beer or two to be had during that. I also want to put a big plug in for a couple of times. Please come and say hello to us at ASA if you meet us. MD's going to New Orleans in a week or two. I'm also doing a director of the Azure Ultrasound Workshop in Chicago, and there's a couple of spots left, so I want to put in a plug for the Azure Ultrasound course. Please go to the Azure website if you want to learn to do ultrasound guided regional anesthesia. It's a phenomenal day and a half.
Yeah, great course.
And also in spring, the Azure Spring meeting. It's 100 years since Gadsden Labatt held the first Azure meeting. I wasn't there at the first one. Didn't make the second.
Just missed it.
So we plan to have a big party and big celebration. And when the 200th event comes, 200 years comes around, you want to be in the big photo that's taken. I was there. So please make sure you find time in your diary for Azure's.
Hollywood, Florida.
Yeah, Hollywood. Yeah, it's a lovely hotel on the beach. So I'm sure we'll all be in the meeting.
Hollywood.
All right. We have got, somebody asked here, blocks for sternotomy. So what's your favourite block for sternotomies? What do you think?
I'm a fan of, should I just throw a can of worms on the table and say ESP? No, I won't do that. No, I like Parasternal. So,
So ESP sometimes gets maligned, but there are a couple of good studies showing that ESP works.
I know. I know it's a contra. I'm just.
Yeah, but the quest was parasternal. So let's see some parasternal.
Parasternal. So this is an intercostal block of on the anterior chest, as opposed to usually we do intercostal blocks on the side or the back of the chest. And what we're going to look for here is we put the probe parasagittal, and what we're seeing there is some subcutaneous tissue. We see his Pecs muscle, and we see some oval structures. Now, if we go real medial, boom, we're over his sternum now, so we can't see anything. It's just bone. And then we'll come back lateral, and very nice. So we see, just going to move it to there. We see these oval structures. Now, those are actually, they look a bit like ribs, but it's costal cartilage because we can see through them. As opposed to going out more lateral, that's his rib. So there's a rib, and there's a costochondral junction there, and that's cartilage. So that's typically where I'll do the block, right about there. And there are two different versions of this. As is often the case in regional anesthesia, everyone wants to have their block that they've described, and block A works better than block B. But here is the skinny on this.
Let's see these. Let's see this up
We-
close.
We've got costal cartilage, we've got pec muscle, so the superficial parasternal would be done in this plane here
So
between...
there's a little cross on the screen. I hope everybody can see. I've blown up the ultrasound now, so everybody can see the dancing cross. Follow the dancing cross.
And so there's a fascial plane between pec and intercostal muscle here. So in this plane here, and honestly, this is the approach I like because it's shallow. Usually the spread is good. Sometimes I have to chase it a bit. I'll often come in at the corner here from above or below and try to just jam up against that costal cartilage to try to lift that pec muscle up, and you'll see the local run up and over the cartilage. There is a deeper approach which brings the needle down to below the intercostal muscle, just above the pleura here. Now the nerves run up through this, so it doesn't actually matter which one you do. You will get the nerves. It's a matter of which do you think is better in your hands from the safety point of view and from a spread point of view. Sometimes I'll get challenging spread on this one and I may flip to this one. The other thing to note is that if I go a little bit more medial here, you see a different structure there.
What's that structure? Medial, Jeff?
That is the one that's pulsating.
The one.
So that's the internal mammary artery, and you can, if you turn the other way and go, so there's James's sternum, and then right where the crosshatch is now is his internal, that's his lima. So your cardiac surgeon's not going to thank you if you do an arteriotomy into the internal mammary vessel. So another reason that I like to default to the superficial block instead of the deep one. And then the question is, how many do you do? There are approaches that do just one. So you've got the big portion of chest wall here. I think the spread is enough that I would choose to do, if that's second rib, third rib, fourth rib, between 3 and 4, I'll skip a space and then go down to this space here. And then that way you get a nice coverage of the whole chest wall. So 1, 2, 3, 4 injections of 10 mils each. Does a good job.
So we had another look at this in the cadaver lab at UNC. Our fellows last year dissected out, I think, 12 chests. And Monica and Nanda, I think, had a poster at Arthur Spring meeting. Superficial versus deep. Spread was the same with both. So if there's one's more superficial and safer, I think it makes sense to choose the superficial option.
Yeah.
It looks like we got about a 3 or 4 level spread. Was kind of the maximum spread with methylene blue, so that we never really got much more than that. But I think, rather than looking at all the options, I think the superficial option is gonna help.
Gonna win. Yeah.
Yeah.
The other thing I'll say is that when we're doing this for cardiac surgery, the thing that hurts them often more is the epigastric chest tubes that are coming in the upper abdominal wall. So we'll do a little rectus sheath block right there.
So rectus sheath and external oblique intercostal are things that people have asked to show. What a segue.
Yeah,
like
just toss them up and yeah. Okay, rectus sheath. Fantastic block. One of my hashtag favorite blocks. And because the anatomy is just so nice, as you're going to see. Now, I haven't pre-scanned James's rectus. I don't know what it looks like, but oh my God, there it is. And golly. So we've got some subcutaneous tissue here, and then you can see his nice dark rectus muscle. And my probe is, as you can see, transverse just off the midline. What you should notice is there's this train track, this white train track on the bottom, or trolley track, and that's the posterior rectus sheath. And so there's his midline, and there's his other rectus muscle, and you can see he does in fact look symmetrical. Well done. And then as we come out, there's the linea semilunaris in the middle of the screen, and the beginning of the external oblique, internal oblique, and transversus muscles. So if you were to do a tap, you'd keep following those. But here's our rectus, and our goal here is to bring a needle in, come through the rectus muscle itself, and then just land in a potential space between those train tracks and the muscle, and you'll open it up. And there are blocks where things don't unzipper well, right? I mean, I struggle sometimes with tap blocks, for example. But this one, each and every time, just it looks beautiful. So that's rectus. Now, thing to worry about, or not worry about, but be cognizant of, there are some vessels here. And so I'll always put color on just to make sure that I'm not going to nail an inferior epigastric artery or vein. Looks like he's actually okay. If I were to do that for the epigastric chest tubes, I would just move my probe up to the epigastric area, and there's my same rectus muscle. You can see transversus is underlying it here, that wedge coming in from the left-hand side of the screen. Don't worry about that. Just do the same block. Bring the needle in, put it all on top of those two train tracks, right like there. Great block, and you know we've found in that cadaver lab that if you put a certain amount of local in, it does spread.
So it looks like 20. There's a lot of papers said 20 cc's. 20 cc's doesn't seem to be just enough. So really lower the concentration down. 0.2% ropivacaine, 0.125 of butte. 30 cc's fills it from one injection midpoint will fill you right the costal margin, and also go all the way down to the suprapubic area. So for rectus sheath blocks, low concentration, volume 25-30 cc's in adult seems to reliably fill up the back of that rectus muscle in an adult. We got a request for external oblique intercostal. In fact, more than one request for external oblique intercostal.
Okay, all right. Another new kid on the block, as it were.
Yeah, everyone wants more questions about new kids. But let's do this, and there's a couple of good questions asked as well. We can go through.
Oh, fantastic. Okay, good. So this block is one that has been developed to address the upper abdominal innervation, because tap block, for all the good it does, it's good for stuff below the umbilicus. It doesn't really get the upper abdomen. A subcostal tap is sometimes hard to do if the surgeon is also operating in that part of the belly. So for hepatobiliary surgery or pancreatic surgery, if the incision and dressing is there, it's hard to get the probe on. So what's nice about this block is it gets the upper abdomen without having to put your probe or needle on the abdomen. So we're going to look around here over his rib cage. You can see his costal margin here, and the intercostal nerves come around T6, 7, 8, 9, like that. And so if I'll palpate for his xiphoid process right there, and then come straight across to usually just past the mid-clavicular line. And what you can see here is I'm just going to try to show the continuity. So there's, if you go down to the belly, there's external oblique muscle there, and it comes up.
Losing a bit of gel there.
Yeah, there. Let me completely gel you up, James.
Where have you been? Going nowhere.
Okay, so external oblique muscle out there, and then as we come up on top of the ribs, we see it continuing on. So this is kind of an interesting anatomic feature, is that this abdominal muscle comes up and on top of the rib cage itself, and it gives you an opportunity right about there. I'll take the depth down a bit, to bring a needle in and land on top of the rib. You see the rib there, usually about rib 7 or so is where that is. And then you're gonna, it's just like an ESP block or a PENG block. You're gonna hit the bone and try to lift that muscle up. And you see it's very thin here. It's just a slip of external oblique muscle on top of that rib. But if you put 25 mils there, it spreads down here and then gets into both the lateral cutaneous branch and so it gets the entire epigastrium, the entire upper quadrant.
Sonny Kai is asking, will external oblique intercostal cover lower rib chest tubes? Actually, I don't know.
That's a good question. I think, Sonny, it would depend on where the chest tube is entering, because what we're usually trying to get is about
show that camera shot. Sorry.
Anterior axillary line forward for these abdominal procedures. I think if I were after that, a serratus plane block is going to be a winner.
And somebody please put in the chat if you have if you've used this and had success for chest. I'd love to hear about that.
Yeah.
If somebody's been using that. There was in our experience, TTMP block facilitates lima harvesting. Okay, love that. Somebody here, have you replaced tap block with posterior QL? Do you want to just show them the tap in a posterior QL?
Yeah.
Since the chance, but I think that's a good question. And for me, yes, I don't really. And when we actually think about tap block, I think a lot of descriptions people scanned way too anterior and just went with three layers of muscle.
Yeah.
I've always gone fairly posterior, and then we can actually scan a little bit further back and do show you from tap to posterior QL. If we try and sort that out by scanning.
Oh my God, it's going to be.
Do you think we can sort that out? Yeah.
QL fest. Yeah.
QL fest. Okay, so let's start the camera shot, and then we'll put the ultrasound on just with the picture-in-picture, so we can see where the probe is and also the abdominal muscle layers.
All right, so as you can see, we're just lateral to the abdominal midline. There's our rectus sheath. Beautiful. I kind of want to stay there and stick a needle in, James. Just kidding, James. Not really, just kidding. But and then there are our tap muscles, and you can see the external oblique on top, internal oblique. So there's external oblique, internal oblique, and transversus. And our nerves run in this plane, right? Transversus abdominis plane. Now, my probe position, as Stuart was alluding to earlier, is a bit too anterior. If you did this, you might only get 1 or 2 sort of dermatomes, as it were. So what I want to do is come around the side of the abdomen. Give it a little more depth. There we go. So you can travel all the way around to here. And you can see that our transversus, that lowermost muscle, is coming to an end. And this is where I'll do my tap block. I think tap block is great for phalansteal incisions and lower abdominal work that isn't just midline. So if it's coming across the abdomen here, I think a tap block's really appropriate. And easy to do, right? And superficial. So there's my image. I'll bring a needle in like this. And my goal is to bring it across to land about here, near the end of transversus. And what I want to do is unzipper and have that push back into this plane back here. This is the old transversalis fascial plane block. The goal was to put it back in this area. This is also, more or less the anterior QL block, or the lateral QL block. So excuse me. So the idea is you're putting local in this plane right here, more lateral, more posterior to the end of transversus. A little tip here, now James is nice and slim, you can really see his three sort of tap muscles easily, but you know, we live here in the biscuit belt, and it's not unusual to see sort of an 8-layer bean dip, and you're kind of wondering which one's muscle and which one's subcutaneous tissue. So if you tilt your probe back and forth like this, toggle it, you'll see the internal oblique and external oblique appear to run in opposite directions, like that. And that gives you a clue, whereas everything else just sort of stays the same. And that's a clue because they're oriented at 90 degrees, those muscle fibers. So that's a little clue as to which muscle's which. Okay, James, maybe get you on your side, facing that way. I am going to switch probes.
So Taras was saying he taught his surgeons the external oblique intercostal plane block for hepatectomies.
Yeah.
So yeah, good.
Good success.
Good, you know,
yeah. Yeah, our liver transplant surgeons are loving it.
Good.
We are collecting the data now, but the number of cases that do very, very well in the immediate post-op period has been great. So what we're going to do now is I'll show you how I like to scan for the posterior QL.
Okay.
And so my first initial landmark, I'm going to
spinal approach.
I do. I go right through the spinous process. Put a little in the epidural space.
Yeah, yeah.
They feel great.
Yeah, the block works well.
That's right.
30 mils in the spinal.
So I'm going to start here on the midline of the spine. And the reason I do this is because, again, James is slim and has great anatomy. I can pick out his QL muscle fairly easily, but it's not often the case. Bones don't lie. So I'm going to use the bones to show me where to look for the QL muscle. I'm going to feel for his iliac crest, and that's about where I'm going to start on a cephalocaudad plane. There's my spinous process in the middle, and as I go lateral, I can see articular facet, and then I can see his transverse process sticking up like this right here. So it's casting a big shadow. I can't see much behind the transverse process, but that's okay. I'm now going to scan. As I scan more lateral, I'm going to aim my probe into his midline. And I want to swing that transverse process up, so it's pointing up at the sky. And so you can see right in the center of the screen where that line is, there's a tip of his transverse process pointing up like a finger. Now, and the reason this is important is because the QL muscle attaches to the transverse process. So now you know where to look, and we're going to look just anterior, or just lateral anterior to this, and you can see this nice dark muscle here, like a flag off of a flagpole. That is QL, and there's the flagpole here, the transverse process. Down here we have psoas muscle, psoas major. So if we wanted to do a lumbar plexus block, right? Yeah, we'd want to bring our needle in and land somewhere in the psoas muscle. But for QL, the anterior QL, we're going to land here in this beautiful bright white plane between dark QL and less dark psoas. And you can see if we did it here, there would be his transverse process in the way. So what I'll usually do is just shift ever so slightly so the muscle, I'll do that again so Mike can see me, just a little toggle there. So I get the transverse process off the screen. And now I have a clear path to bring my needle in from the medial side, come across and land right there in that plane. What's nice about this is I can do this block both ways with one position. I don't have to turn him the other way, so I can come back this way and with the right sort of positioning of the patient like that, and yeah, there's his other QL, and that caliper line is actually right on the same plane. So he's symmetrical, which is great. So I like that approach, and I get fooled. I don't know if you get fooled, but by soft tissue sometimes.
Oh, it's challenging some of our patients if they're, and I end up just shying away from this block, and some of the patients I have is just a non-starter.
The scan.
Just the size of some of them. The scanning is really challenging. This is really cheating with our model tonight. But who said we couldn't cheat?
Your house, your rules.
So here's a question. It comes up. Somebody's asked, "What's your favourite adjunct or additive to local anaesthetic?" And kind of like my Scotch. Neat. Is
I like it neat.
Neat is mine. What about you?
Yeah, I mean, interesting discussion this week in Blocktober about mixing and pharmacodynamics and stuff. So I'll leave that alone, but I do like a bit of dexamethasone sometimes.
Okay.
And I think the situation where I'll do that is I've got a brachial plexus block or a limb block at 9 in the morning, and if I just use plain ropivacaine, I know it's going to wear off at 3 in the morning, the next morning. And so I want to squeeze out another, 4 to 6 hours out of it and make sure that they get through the night. And so that's where I'll put a bit of dexamethasone in. It's easy. It seems to be safe.
What dose?
What dose? We'll use 2 milligrams in a 20 ml syringe.
2 milligrams. Okay.
Yeah.
I just put it in IV.
Yeah, I know. And
dexamethasone IV.
I know. And there's good. I mean, the preponderance of the data seems to suggest there's a small perineural effect. So maybe it's just treating my neurosis by doing it that way. But
yeah. Somebody says TAP replaced by posterior QL. I end up still doing. I'd probably do the lateral QL around the posterior. That's my kind of one for laparoscopic and robotic abdominal work. We can put these in, and I think the further back you go, I get a higher block than the ultrasound described TAP block. McDonough's original description was a fairly high speed. I think when people started doing it with ultrasound, they're just too anterior.
That's right. Yeah.
I think probably that lateral QL is what was that description that he was doing with the triangle of petite, and there is nothing petite about most of my patients. I can't feel that, so that I think that.
Yeah.
Well, somebody's asked thoughts on dexmedetomidine as an additive, and so Brian Williams did. Chad Brummett did some work on that, and I have used that as an additive. It's not inexpensive. You end up with about 100 mics, and adding it to that, it seems to have a similar effect to dexamethasone. I try to, if I want a really long-acting block, I'll use a catheter wherever I can. I'm not a big fan of additives, but I have used dexmedetomidine and I have used dexamethasone. Yep. I think a lovely work. There was guys up in Dalhousie looked at the step down from the block and really said, if you're going to do a block, you should probably give some dexamethasone to reduce the step down and the analgesia when the block wears off. It just smooths that out. So I think
softer landing.
So yes. We have had requests from everything from head to toe. We've got folks on. We've got like all of North Africa covered, from Egypt, from Algeria.
Yeah.
We've done from Saudi Arabia,
welcome.
Bolivia, and also folks in Colombia tuning in. So this is phenomenal. And thank you very much for sharing your evening, your afternoon, your morning, or even tomorrow, because we have somebody in from, I think, one Australian call coming in. So the chat has been absolutely superb. Somebody talked about analgesia plans for thoracotomy and analgesia.
I'll just say I am a paravertebral fan. You can't beat a good paravertebral.
And paravertebral catheters, I think with ultrasound are easy. We have got some surgeons using intercostals with Exparel and doing individual surgical placed above and below, which seems to work very well. If your surgeons aren't happy, I usually do a paravertebral.
Mm-hmm. I think that's a good. I think I've been very happy with the Serratus for per-rib fractures on the lateral side. And, you know, ESP has been, the good thing about an ESP is that if you're concerned about getting the needle so close to the pleura with a paravertebral, it's a nice plan B. You know, it gets you most of what a paravertebral might get you, hopefully, without the attendant risks, and you get that nice bony backstop to stop your needle as you're coming through.
Favourite username so far is Rambo. Seems a little bit threatening, and he's probably very good with a
needle,
bow and arrow, which makes him very good with needles. He says a best block option for femoral nailing is fascia iliaca alone, or do you need a sciatic?
Yeah, well, you know, it's interesting. So to me, the innervation of the femur derives from the two different plexi, right? So the lumbar plexus and the sacral plexus. So you'll get some of the posterior part of the femur innervated by the nerves that come off the sacral plexus, like the sciatic nerve and some of the gluteal nerves. So, so yeah, if you wanted complete anesthesia of the femur, I think you need both. But we often won't do both. And if you're going to pick one, I'll pick a fascia iliaca.
It all depends on the femoral nailing. If it's a femoral shaft, I'm going to put the good old femoral nerve block in for some of the trauma surgeries. But if you're talking about hips, fascia iliaca or a PENG, I've been doing the fascia iliaca so much longer, I tend to gravitate to that. But the residents and fellows like to see the PENG. It's the new kid in the block. I'm just an old geezer that's stuck in my ways.
Wizened professor with his fascia iliaca.
Yeah, curmudgeon. I've been perfecting that for years now, the curmudgeon. We have a request for ESP. Can you show us the tips and the tricks for the ESP block?
Yes, absolutely. Let's get...
We're going to have to do a bit of setting up, facing away from it, or just turn on the side?
Let's turn on the side for starters, and we'll see if that works.
We'll turn our model on the side, and we'll do a little bit of scanning.
So...
more gel, as always.
So, for ESP...
Okay, so you started pretty lateral there when I look at that picture.
Okay, I do.
I'm going to put on the picture-in-picture after showing the big one. Okay.
Yeah, so I do start lateral, and the reason is because I like to see ribs. Ribs are really easy to recognize. They have a rounded contour. You can see here a rounded contour, and you can see pleura. So I know what I'm looking at. I'm a simple guy, Stuart. I'm easily confused.
You are a simple
I'm an
guy.
old man.
There's a lot of chat just come in going agreeing with the fact that you're simple. Somebody said special. But, somebody's asked for PVB, so we can do a twofer here,
oh
can't we?
My gosh,
Thank you for asking for PVB. We love the PVB. It's as old as we are.
So with either block, what I want to do is know what level I'm blocking. So if I start at our ribs, I'm going to start to scan up. And here I am, scanning up, scanning up. I've got some ribs. I don't know which ribs these are yet because I don't have a good sense of that. But as I come up over the shoulder, there's still got a rib. And there's a rib. And that's it. So that's rib 1 in the center. Rib 2, rib 3, rib 4, rib 5, etc., etc. So you can precisely smart bomb target which level you want by doing that little maneuver. So now, I've got my ribs and pleura. This is too far lateral to do either one of those blocks. So what I want to do now is scan medially, and I'm going to track those ribs, track those ribs, track those ribs, and at some point you're going to see a shift from rib to a new bone, and there's transverse process. 2 transverse processes there, and you can see there's rounded rib with pleura, and there's squared off, more squared off, slightly less deep, more shallow transverse process.
Oh, that's good there. Yeah, that's a nice change from the rib to the transverse process.
TP, rib, TP. And friends, I will spend hours just on a slow day, rib, TP, rib, TP. It's mesmerizing. But you'll notice you also lose the pleura, and that's a good sign that you're in the right spot. Okay, so once you get your TP view, you're almost home free. And depending on where you are doing your scan, you may see other muscles on top, like trapezius, or there's a bit of rhomboid muscle there. But remember, you've counted down from the top, so you know where you are. You don't have to use the rhomboid as a surrogate marker. Now comes the needle. So your needle can come in from below or above. The original description of this had the needle coming down and hitting the bone on top and lifting the muscle up. But what I find is that tends to, many times, pin the muscle down to the TP, and my injectate goes intramuscular. And I've had some,
twirl that needle.
The Grant twirl? The Grant twizzle?
Cigar. But yeah, I end up when I get down there, if you do find it, the local bounces back, sometimes just rolling that needle, rolling it back and forward, and it gets you through the different muscle layers that you have kind of pinned down, potentially. Yeah, and the other,
that's right. So the Grant twizzle is one move. Let's get that trending, okay? And then the other is, I'll come to the corner of the transverse process. So instead of hitting the top here, I'm going to come to here. And so my needle's coming across, and I will click through that epimysium of Rectus spinae and aim just for the corner. And then that way you'll see the local will go up and over the TP.
I'm sure the whistle on the
it makes that it makes that noise. It's all about the sound effects, man.
You hear that in your head every time you hear the whistle. Yeah,
that's right. So that's ESP, and we'll the nice thing is you'll see that local going up and over, and then you can either just call that a day or put a catheter in or what have you. 30 mils is what we use to get about 4 to 5 levels down, 4 to 5 levels up in the thoracic zone. If we're doing sort of more thoracolumbar or lumbar, that spread isn't quite as much because the muscle's less compliant.
Yep.
Now, for PVB...
let's go to show this.
Camera A, camera B.
Camera B.
Camera A, camera B. So there we are, back to our rib view.
Friend the rib, yeah.
Yeah. And so I'm going to do the same maneuver. I'm going to keep going medial, medial, medial. I'm losing it. There's my TP. Now that I got that, I'm going to just tilt slightly lateral until I get a hint of pleura back. Okay? And I'm kind of at the TP rib juncture. You can see I'm sort of halfway in between. And where the calipers are now is the very lateral recess of the paravertebral space. And so this affords you an opportunity to come in out of plane. I'll come in like this with my needle out of plane and drop it straight down into that space. Now, you may be thinking, gosh, that seems a bit risky going straight at the pleura. I make good use of hydrolocation. So as I'm coming through the superficial muscle of the chest, I will give a little squirt of saline, and then come down, squirt, and squirt, 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 squirt. And then a final squirt, you'll see the pleura go boom.
More audio, disgusting. So, learning, we teach our residents in plane because I think it's a good technique to learn, but learning to do out of plane blocks well, I think part of the technique is being close to the ultrasound probe, watching when you cut the plane, and then even going even steeper to follow the needle down, or tilting the probe to follow it, and you can actually walk the tip of the needle down even when you're out of plane. Do you want the pen?
Do you mind if I?
Yeah, on you go.
Thanks. That's a good point. No, I was just going to say, as you're coming across medial and you get your TP, then you tilt slightly lateral to get the pleural view. That creates that slightly lateral orientation of the beam. If you come straight down with your needle, then the beam and the needle meet at depth, where the so you'll see it nicely at the.
So I actually have the probe the transverse view. I do it out of plane, but I put the probe transverse. I watch the rib, and then let me do the picture here. Go to 3 picture. So we can get a transverse, I can see the pleura, I can see the rib. I work out my depth using the depth gauge on the right side of the ultrasound machine. And I'll actually usually slide to where I don't see the transverse process. So you can slide up and down the back.
I'll try to get a...
Okay, it shows the nice shot of the transverse process.
TP, there's
There
TP.
we are, okay, and then I'll slide down so I don't see it. And that's where I'm going to put my local. So I'm a little bit to the left of midline here. Yep. And
is that
so how low do you go? How close
ligament?
you go? Well, I know I read the description, the MT plea block, the midpoint to transverse process from the folks in Canada talking about that. I still like to see the pleural descent. We did some MTP blocks, and what I want to see was if you do a large volume MTP block, do you get multiple level spread like you do with paravertebral? So we injected MTP blocks in cadavers, and we couldn't see the kevlar and caudad spread. Apart from then, we took the thoracic vertebrae off and looked at the epidural space, and we got multiple level spread with a large volume in the extradural space. So I think if you go all the way down and go close where you do a traditional PVB, and I think a lot of times probably when we did traditional PVBs, we didn't really know who we were, and sometimes get multi-level spread. Yeah, we were probably getting that epidural causing the spread. But so if I'm doing a PVB, I like to go pretty deep and watch the pleura.
Pretty close, but even close enough can be good. That's what you're saying.
Yeah, it seems to be, and maybe the mechanism's different, but it works.
Well, so the doctor who invented the MTP block, Iwana Kostash from Ottawa, I remember her saying once at a meeting that she was talking to a neurosurgeon friend of hers, and he said, well, there are no watertight compartments in the spine. So you think these fascia planes really hold things in, but maybe they don't quite so much. What's next?
I asked a question, do people want to see this again? I think we're going to have to arrange another one because I've got a lot of yeses. But right now, we are past the hour.
Can we squeeze one more thing in?
One more block. Somebody would see transverse orientation for PVB, so I think we covered that.
And this stream will be up on the YouTube channel too, so you can go back and review all this stuff that we've scanned.
Yeah, and somebody asked for Adductor canal, nerve to vastus medialis.
That's a good one. Let's do
that's
that.
One of your favourites. So this will be our last one for today, and I'm going to say thank you very much to everybody who is tuned in. Thank you again to folks at Sonosite who loaned us, and also folks who got volunteer equipment for folks at Samsung as well.
Yeah, appreciate that.
So let's have a look at this.
Adductor canal, or depending on your
let's not get into this, the naming disputes, okay?
Midpoint of the thigh, right there, okay? I'm halfway up from the patella to the groin crease. Okay. I'm going to put my probe on. You can see that James has kindly frog-legged his thigh here, so we're looking at the medial thigh. There's his femur. You can see he's been spending some time on the treadmill here. This nice muscle definition. As we slide medial, we're picking up, there's our sartorius at the top here. So that sartorius muscle, don't need quite so much depth. Okay, that's better. And then over here is the vastus medialis muscle, and over here is the adductor longus muscle. So there's a femoral artery. If I relieve the pressure, you see his femoral vein come up here on the medial side. Now, the structures that we're interested in for the adductor canal block, we're doing these mostly for knee surgery, are the saphenous nerve, which lives right here. That's a little hyperechoic smudge beside the artery, and the nerve to vastus medialis, which has a bunch of articular fibers that supply the joint capsule, where a lot of the action takes place for knee surgery. So the trick to this is that you can't always see the nerve to vastus medialis on the scan. Now, if I were to get a gun to my head, there are a couple of options here. One is that it could be right here. A lot of times they're right side by side, and until you get a needle in there and put some injectate and see them peel apart, you can't know for sure. Sometimes it's way out here too. I don't really see. There might be something right there. So, and James is a nice, fit, slim individual. So if we can't see this reliably, if I can't say with 100% certainty where his nerve is today, how do we solve this problem? And the answer to me is nerve stimulation. So as you bring your needle across from lateral, I will be coming this way through this plane, and I'll have my nerve stimulator on, set to 0.7 or 0.8. I'm going to have a hand on his medial thigh, right here by the kneecap, over the vastus medialis muscle. And as we get close to that nerve to vastus medialis, we will, actually there is a little hyperechoic density there. That might be it there. You're going to start to see a brisk boom, 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 just medial vastus twitch, not rectus, intermedius, or lateralis, just medialis. And that tells you that you're in proximity to that nerve. Okay. Give a little squirt of saline and then coat it, and you're in good shape. Well, and that makes sure that you get the nerve, but also protect it, because
there have been a couple of cases of injury to that.
I mean, it's right in the line of fire as you come across to the
So
saphenous.
I don't like sliding right along the fascial plane. I'd rather come down.
You're a trans-sartorius kind of guy.
I just wonder if going right along the fascial plane is heading
Yeah.
anyone right into that nerve to vastus.
I think so.
I've been lucky enough. I think I've not hurt it yet, but I've read a couple of case reports where there's been some.
Yeah, I mean, it lives there, but I think that's where the nerve stim keeps that advancing wave of electrical energy, gives you that early warning system.
Yep.
And so once you've done that and isolated and blocked that nerve, we can kind of get over it and then get to the saphenous. And the two are separated by a vasto-adductor membrane, so it is actually important to get both, as opposed to just dumping it. For years I did this block just putting local beside the artery.
Yep. Raj Gupta at Vanderbilt. Hey Raj, thanks for tuning in. Asks, how do you discriminate sartorius twitching from the muscle?
You can, it's a good question, because both of those muscles are in that area. The sartorius down by the knee is going to be a little more medial, and then you can palpate the vastus medialis oblique head is a chunky little knob of muscle right by the kneecap. So you can sort of put your fingers over that and maybe feel, sometimes I have that question myself, and I'll be like, wait a minute, is that, and you can kind of feel around and feel for which one is sartorius and which one is.
Before ultrasound, when I was trying to do a saphenous nerve block above the knee, I'd actually use the nerve stimulator, put it in the leg, and look for them, turn it up high to get a motor twitch deliberately of the sartorius, and then pop underneath it, and then put the local anaesthetic in to get the saphenous nerve block was the technique. Andy Chen asks, do you see significant motor weakness of the vastus medialis after blocking the nerve to it? I mean, he's really worried enough to impede PT or recovery.
Yeah, so it's a good question, because here we are trying to do these motor-sparing blocks for knee surgery, and yet here we are telling you block the nerve that supplies that muscle. I think the answer is no, we haven't. The TLDR, we haven't really. They can still do their PT. I think where we see it is as you, it's the very last thing to fire as you lock the knee in extension. So they got to be a little bit careful when they're coming downstairs and that sort of thing. But that's all part and parcel with their sort of rehab precautions and considerations. But gross power, no, not really.
So we've had a couple of other things. We've got to come back. We're going to look at geniculars. We're going to look at popliteal. So there've been lots of other questions. So, but we are officially out of time. Mrs. Grant is going to make me empty the dishwasher, take out the trash, walk the dogs. So I've got chores to do tonight, and if I know it's good for me, I'll make sure I get them done.
Thank you so much for joining us for this first. Sounds like it's the first of more to do.
Yeah.
Sounds like there's more material to cover. So we really appreciate your time and tuning in. And the broadcast will be up on the YouTube channel, so you can go back and watch if there are things you missed.
And the pub quiz.
Saturday the 28th, we will put more promos to come, but get your trivia team together and you can earn bragging rights and win prizes for your regional anesthesia knowledge.
Yeah, thanks for tuning in, folks.
See you next time.
Bye.